Good morning, everybody, and welcome to our Bitesize series for today. So it's part of our innovation program of work that we've been undertaking from September through to January. So we've got into a bit of a routine now. And today I'm pleased to say we've got colleagues from the Rotherham Foundation Trust. So I've got Chantil and Naz. And the item we'll be discussing is the digital weight management program. So I look forward to that. It's quite topical because I'm sure lots of people will have seen in the media and the press that it's a weight loss and certainly the therapies that have come to light of kind of it's on people's minds and lots of people are looking into those. One of the reasons we support these bite-sized programs is clearly innovation drives progress, enhances problem solving, and it's a way of fostering growth to support our health and care industry. So we're hoping that you'll enjoy the series, but particularly the item that we're going to discuss today. So without further ado, then can I introduce Naz and Chantil, and we'll hear from your presentation today.
Thank you, David. Thank you for inviting us, and Natalie as well. It's a pleasure to be here. I'm just going to share my slides. So just give me 1 second. So hopefully you should be able to see them. So yeah, thank you everyone. Thank you for joining us. My name's Nazreen Iqbal. I'm the Healthy Hospital Programme Manager over at Rotherham Hospital, and I've got my lovely colleague Chantil Calvert, our clinical advisor nurse who supports the programme and does a lot of the operational work on this programme. So just to set the context, so obviously all of us are here on the call today. We know obesity has been rising steadily for many years. Prevention's needed and treatment options are needed to tackle it. We're really working against poor diet and obesity at scale. We live in an obesogenic environment with major drivers that lead to poor physical health and mental health. And unfortunately, that makes people die earlier, so early mortality. Obesity places a significant and growing burden on the NHS within the current context. Got people coming in again and again, and lots of issues around their weight. So if you could control that, that would really help the burden on an NHS that's kind of under a very tight financial envelope. Rotherham, we know, is one of the 20% most deprived districts in England. And our life expectancy here for both men and women is lower than the England average. And it's not something that we should just accept and take that as is. We need to do something about that. A large percentage, 60%, 68% of Rotherham adults are overweight and obese, and this was back in 20 and 21 where we actually started looking into this programme. I looked at the figures for this year, so the latest data that we have. So for 22 and 23, we know 3 in 4 adults are overweight or obese in Rotherham. So that's 73% of adults in Rotherham are obese, and that's a shocking statistic. We know obesity has been classed and it is classified and defined under the BMI, body mass index of 30 or above. And then that can be sort of altered for ethnicity as well. And according to NHS digital data in 2019 and 2020, it was estimated that there were just over 1 million hospital admissions where obesity was recorded as a patient's primary or secondary diagnosis. So we know that there's lots of work that needs to happen really to address obesity. Now, we were invited, our hospital, Rotherham Hospital, were invited to apply to be part of a pilot for NHS England, focusing on lifestyle weight management support for people with obesity and coexisting long-term conditions. There was already an NHS digital weight management programme that GPs could refer to, and that's the first column on the top there. So GPs can refer to a 12-week programme, and that was a national programme that was running. This pilot actually aimed to replicate the above, but look at correct elective recovery pathways by providing a weight well service provision. So that's the fourth one. So this is the one that we're talking about today, the hospital elective care waiting list that we're going to discuss. Through collaboration with NHS England and selected sites, the programme would develop and then implement a referral pathway from selected elective care waiting list, excuse me, to the National NHS Digital Weight Management Programme, looking at lifestyle and behaviour change. And Chantel's going to talk a lot more about that in more detail, but the programme commenced in April of 2023. And just to set the scene really where we're at with Rotherham in terms of weight management services. So we know we've got the public health messages at tier 1 and the making every contact count. And then tier 2, which is where this programme fits in, our digital weight management service is that tier 2. But we also have a face-to-face provision through a provider called HealthWave that do that as well. And unfortunately, tier 3 and tier 4 services have been decommissioned. So we don't currently have any of those services in Rotherham. We know the Royal College of Anaesthetists tell us that advising patients to lose weight in a steady and healthy way before surgery can help their recovery time and support patients to get fitter faster. There's lots of research that indicates excess weight can increase the risk of complications both during and after surgery. And people living with obesity are at a higher risk of developing life-threatening complications during surgery associated to anaesthesia and cardiovascular stress. And higher weight pre-surgery increases post-operative risks associated to wound infection, poor wound healing, and cardiovascular incidents. And I mean, I speak to consultant doctors all the time, and they tell me just people losing 5% of their BMI has such an impact on the way they handle surgery, because these patients are physically heavier. So it makes the doctors very happy, makes their job easy if they've got a 5-6 hour surgery. So just thinking of it from a practical perspective. And when the team was sort of looking into the evidence base behind why we should be looking at these surgeries, elective surgeries, lots of people are waiting, what is the data? So what's the percentage? And actually, if you look at general surgery, the number of patients that had a BMI over 30 was 20%, 21% in 2019. And then if you looked at 2021 figures, 2022, that went up to 24. So these were patients that had the data recorded. And then for orthopedics, depending on which one you're looking at, so hip replacement and knee replacement, we started off with 24.63 and 41% with a BMI over 30. And then those figures shoot up for hip replacements to 32.42 BMI over 30 in 22, and then 53% for knee replacement. So these patients are, obviously within that category. And definitely ready for this programme. Our goal was to influence our patients to take part in work around that waiting well. So whilst they're waiting for their operation, what can they do to take responsibility for their own health and their weight? And the aim was to strengthen our referral pathways to locally delivered free weight management programmes, whilst planning further engagement with our clinicians to increase referrals to this service. And other pre-rehabilitation lifestyle services based on individual patient need. I'm going to hand over now to my colleague Chantel, who's been working since the beginning of this programme and does the operational support. Over to you, Chantel.
Thank you, Naz. So this is our referral pathway, and it's just to show you from the onset. So the specialities weren't chosen by us. They were actually chosen by NHS England. So the specialities included general surgery, and this is hernia repairs and gallbladder surgery. Orthopedics included hip and knee surgery, and gynae was full abdominal hysterectomies. So what we then did from the specialities is the clinical lead by myself. We looked at the patients and we looked at the BMI. Now, some patients mainly had their BMI pulled off via Power BI, others didn't, which meant a manual search of records. However, what we did from this is onward referral if the patient consented to the 12-week programme, and that was the offer by phoning them and asking if they want to be part and parcel of the programme, which was free. And they got 3 options. Mainly, one was Slimmers World, the other one was Axia support, and the third one changed on a regular basis. That was then documented. The patient was happy to actually take part in the 12-week programme, and the consultants were able to look at that in the patient's Meditech records. Patients that didn't want to do the online programme just because of digital awareness, people were scared of scams, people weren't always able to use the mobile as we do. Even patients in their 50s and 60s seemed sceptical to use the actual digital pathway. So we could refer them to HealthWave, which is our community partners. And that was either by giving them a direct contact number for them to make the referral, or we could make the referral for them. So this was much more of face-to-face support over a 12-week period. If the patient declined, so some patients with a BMI of 30 or 27.5 adjusted for Black and ethnic minorities, it might have been gym goers, it might have been young population, and therefore when you look at the BMI, it might have been quite vast on the actual data that we could see via Power BI and clinical records. But actually when speaking to them, they were physically fit, they were going to the gym on a regular basis, they ate well, they reported that. So for some people, they felt as though they didn't want to take part, or for some other people, they were already classified as being obese and were supported by the GPs. And some people, as we've gone through the pathway for the last couple of years, have been put on Gero and Wegovy injections, so they didn't meet the criteria any longer. So just documented that the patient wasn't interested at that point, and that were documented back in the patient's records. So that's the actual pathway itself. So Naz, thank you. So from December 2024, we changed the process from the clinical nurse telephoning all patients instead to a text message being sent. So patients that were documented with the BMI recorded in the Power BI, we could send the text messages on, and that basically asked them whether due for surgery in less than 18 weeks, did they have a BMI over 30 or 27.5 adjusted, did they want support via health professionals in regards to weight management prior to the surgery and the reasons why. And, you know, the documentation then came back and I could actually record from the text messages whether they wanted to actually continue with the actual 12-week programme. So this reduced my work input. I do work part-time and I have got other projects that I work alongside the Healthy Hospitals team with. So that did reduce the output work of telephoning all patients. The 209 text messages sent, 86% of patients responded with a yes or no, and non-responders get one chase-up phone call by myself, and this is documented in the records as well. So all those with missing BMIs, they are always phoned, and often the evidence is telling us if it's not already recorded, the patients sometimes don't know, and they don't have the ability to actually weigh themselves at home, because a lot of people don't have weighing scales any longer. So the next row shows us, no, I don't want to take part in the actual programme. If you can just go back for me now, sorry, thank you. With 71 patients. Yes, I'm happy to be referred to the NHS England programme to take part in the digital weight management programme was 103, and the blank ones were 5, which meant they didn't respond to it. So there we followed through. So that equated to 179 of the patients from December 2024. Thank you, Naz. So what is an NHS Digital Weight Management Programme then? So it's a weight management programme offered by digital programme content. It's not face-to-face, but it's provided at no cost via local systems. So people with access to a mobile phone or web browser could access the actual programme. The programme offers behavioural context in relation to lifestyle. It's delivered over 12 weeks, consecutive weeks, and the programme is available to adults who have got an BMI over 30 or adjusted to 27.5. Now, the one that says about have a diagnosis of diabetes or hypertension, we actually didn't consider with our patients for the elective waiting list. We could just go past that, where if you were in general population, so you were referred by your GP or your pharmacy, they have to take that as a consideration. So once people are referred on to NHS England, depending on their BMI, they either get digital context only, which is level 1 support. Level 2 included 50 minutes of support via a health coach. So that's contact via health coach and telephone calling. And level 3, so somebody with a BMI of 40 to 45 and above would have got 100 minutes of health coaching, and which they can refer to. So it's commissioned by NHS England and delivered over different project types. So it's quite an in-depth programme for people when they start it. So patient eligibility then, the patient has to be over 18 years of age, they have to be able to consent to the programme, they have to have a body mass index which was recorded of above 30 or adjusted to 27.5. Is not planned for surgery in less than 18 weeks. Now, yesterday, as I explained in the behaviour science programme that was delivered against, is the 18 weeks is because it's a 12-week programme, but when the referral goes from us, the Healthy Hospitals team, the patient has 5 weeks to make a decision whether to join or whether not to join the programme. And I do think that probably needs to be looked at from an NHS perspective, because I think we lose people via the motivation. So as a mobile phone or email, and have the technical skills required to access digital weight management programme support. And this was quite surprising, because people that I've spoken to in the 50s and 60s will say to you, I'm not digitally able to actually access the programme, which is fine, because then we can use our community partners. And we also believe that the patient can benefit from the ongoing programme as well. So who can't be referred then? A patient who is considered as having moderate to severe frailty. Now, generally in our records, when I look at the patient's details, I can look on the Meditech records, and sometimes it's actually recorded that the patient may have dementia, may be frail, and I wouldn't phone that patient at that point. Patients who are pregnant, patients who have an active eating disorder, and that's obviously usually recorded as well, have had bariatric surgery in the last 2 years, and the one that can't be referred now is if they're already having ongoing medication prescribed, or some people, when I phone them, will have bought medication from an online pharmacy, and at that point we wouldn't encourage them to take part in the programme, because it wouldn't be of any use to them really. Patients for whom weight management programme is considered to pose a greater risk than harm and to benefit them. So this is our referral figures so far. So we've had 454 referrals into the actual digital weight management programme. 315 was triaged. The surprising data, which I think is always a good thing to look at, is to look at the IMD data. So we've got 34% of our patients from IMD 1, and we've got 23% of our patients from IMD 2. So that's the inequality index. We've got 93% of our patients which were white British, 67% of females, and 33% of males, which I think it gives you a good variation of where our patients are from and what context. So what we did is, because NHS England said they're going to do an internal review, but we felt as though we needed to feed back some of our specialities about our patients so far and what's happened with their weight management. So we decided from the first year to take the first 150 patients that had gone through the programme, just to give us a bit of an overview on where we were. So the internal evaluation then started December 24. So we had a 150 patients who we manually called. So we had 57 patients with no answer. We did actually try to ring the patients on 2 separate occasions. We had 10 people that they said they didn't want to take part in the evaluation, was absolutely fine. And we've got 83 patients who were happy to discuss their experience with digital weight management, and 31 completed the interview with full details. So who benefited then? So we had 7% of the patients surveyed could not remember taking part in digital weight management programme. And I think this highlights the actual drop off, the 5-week delay that patients are given, because we can recruit and we can send the referral on, but then if they've got a leeway of 5 weeks to make a decision, we think that 7% came from there. 3% of patients surveyed reported that NHS England said they did not fit the criteria for the eligibility. And again, when I fed back the RU numbers of our patients to NHS England, they had actually been supported by NHS England, but the patients had reported a BMI less than 30 or less than 27.5 from when they were initially seen in clinic. So that would have been patients that have actually lost weight, incentivized by themselves before the surgeries took place. And we had 1% of patients who felt the programme they could actually cheat. So if they didn't have any coaching from a health coach, they could report back on a weekly basis. And I think that was quite highlighting, but very honest of that patient as well. And we had 42% of patients who decided that after NHS England contact them not to be part of the programme. And I think, again, I keep referring back to the 5-week window where people can drop out. So the motivation then weans, and then we lose them at that point. The successful point was, though, 47% of our patients felt that they'd benefited from taking part in the programme. So how much weight did we lose then? So of the 31 patients reported to have lost weight, the weight loss did vary from £2 through to 21.3 kilograms, which was 3 stone and £5 over a 12-week period. The average weight loss of all patients was 1 stone, £6.5, which was brilliant. And the overall weight loss of the 31 patients that took part collectively was 51 stone, £3.5. So I think it's immense when we look at that in comparison to what weight they had initially before we started the programme. So to give a comparison, we asked NHS England of their data collected of what they did in regards to the GP patient pathway, and this showed an average weight loss in the first year of delivery of £8.5, while Rotherham's average weight loss was over 1 stone and £6.5, so it almost doubled that. So I think that was brilliant. The wider benefits when patients were asked, 25 patients reported they felt that fitness levels had improved because they didn't weigh as much and they were able to do more. We've got one patient who was a diabetic whose levels had returned to a normal level for them, so that was fantastic. And we got 22% patients felt motivated to complete the 12-week programme fully. So out of the 31 patients then, 11 reported to have continued weight loss after the 12-week programme. So one patient reported to have joined Slimmers World directly, and one patient reported to have lost a further 3 stone after the programme had finished. They were motivated to continue the programme over, which is brilliant. So some patients did report, so 11 reported feelings of isolation. So most patients said because it was a digital platform, they felt as though a group support would have been more beneficial so they could bounce off other people that were doing similar programs, they could share ideas. Some people was bored of the amount of emails, and what I would say in context of this is the more interactive the patients are, the more information they receive. And some people were worried about mobile device phishing and scams coming through. So I think that was one thing that we'll have to think through. So overall, 25 patients would recommend the Digital Weight programme to other people, which I think was quite nice. So the case studies then, a couple of case studies that I've got for you. So this was a lady who was probably about mid-50s. She was asked to take part in the digital weight management program pre-operatively. She said that she knew she was overweight and she still is. The option was to support was both simple and easy. I chose the option which was Slimmers World Online. She'd previously done Slimmers World, so she was comfortable and confident with the actual program. Pre and post-operatively, the supports made a reevaluate a relationship with food and the reasons why she actually used to eat in the first place. And it wasn't always through hunger, but boredom for this lady. So she would definitely recommend the support to other patients, which was free. So I think that's a really nice one. And the second case study was a chap that was due in for surgery and his wife supported him throughout the journey. So the support was offered suited my needs and I thought it was a good idea to be offered by the hospital. Me and my wife did the programme together, which spurred me along to lose weight prior to my operation. My wife and the information received really encouraged me to lose the weight. I knew by losing weight I would be better for my health and recover from surgery. And that's the point that I always sell it to patients. I would recommend the support to patients if they have a family member to help, then they aren't on their own to do this. And I think that just evaluates a couple doing that as well, which is lovely.
Thanks, Chantel.
Thank you.
Thank you. I just wanted to summarise really as we finish off. It's my final slide. I guess we've learned a lot from doing this programme, but a digital weight management programme can be embedded within elective pathways, and it's a brilliant offer to patients to weight well, despite, I guess, our initial concerns about, are we looking at patients and we're offering something online? Is it going to, are people going to be able to access it in Rotherham? Rotherham's really deprived, but actually, for some patients, it works really well. And where people are able to use technology, I think it definitely ticks the box. And when people are waiting for surgery, it's a real motivator to actually let me lose some weight before I have my surgery. I'm going to have a much better recovery. And I think the other benefit of the programme, Chantel's a nurse by background, and I think having a nurse, having that knowledge that she has and the way she approaches patients and can talk to them and coach them in that initial calls really has been really effective. But obviously it's a cost. So every time Chantel was ringing a patient, it was taking her away from other parts of work that she could do. So that's why we brought in the text messaging service. And I think for me, the lesson learned was actually text messages do work and it can reduce workload. But so now Chantal only rings the patients where BMI hasn't been recorded or the patient hasn't responded. So using her time much more effectively with this program. But we also know that this program it's not a one size fits all. So, you know, the fact that we have got HealthWave, who can offer that face-to-face support for patients who maybe don't have technology and aren't comfortable with it, or just want that group support, we can offer that. So that's brilliant. It's not an either or. We need to make sure we can offer both services. And I think Chantal's put there need to take into account the motivators. So definitely a free program where there's no cost and the limited barriers for people does make a real difference. I've talked about digital exclusion. I've talked about text messages. One of the other challenges that we have had is getting the clinical colleagues to buy into this program. So making sure that the BMI data is recorded, because that makes our life easier. The reason why we also did the evaluation ourselves internally was because our consultant colleagues were saying, actually, why, we keep referring patients, but what's the progress? And because we're kind of the middle partners, I guess, with NHS England, we were kind of waiting on NHS England to do their evaluation. But as we know, NHS England are going through their own challenges, and we just wanted something in the interim to keep our consultants happy and share that data. So yeah, sharing that progress of the program with the clinical teams is really important. But also I think the fact that our patients are coming from those IMD1, IMD2 levels of deprivation shows that we are addressing health inequalities, which is really important in this context. So thank you, everyone. I hope that's been useful for everybody. That's our presentation finished. Any questions?
So as I said, please do stick your questions in the chat or the question and answer session. While we're just waiting for those, just a couple of reflections from me. I think the first thing that struck me was you've highlighted the challenges and the need for this. So you've quoted or you referenced index of multiple deprivation. Interestingly, on the 25th of October, that was republished. Unfortunately, the bad news for South Yorkshire is that we have as many people in the lowest deciles of deprivation in the country as we have done previously. So people will be aware of the formula core 20, and for Rotherham that's 35%, for South Yorkshire as a whole that's 37% average, and that equates to about 500,000 people. So it's not an insignificant amount of our population who are not only impacted on ill health, but also challenged from a financial point of view. And then the other thing I was going to reference is just we are reviewing the weight management services across South Yorkshire as a whole, because you were saying at the moment Rotherham doesn't have the tier 3 and 4, but we shouldn't look at Rotherham in isolation, and we are trying to see how we can provide services across South Yorkshire in a more aligned way. So that piece of work I'm close to as well. So I'm just looking for any questions that people will have brought up. So please do put your questions in. So I do have one, just because this is a digital program. Did you give some thought to sort of digital inclusion and for those patients who aren't able to access? I know you did touch on it briefly, but could I pose that question to start, please?
Yeah, I mean, I guess I can take that. I don't know if Chantal's got anything to add, because I know I've been here 18 months and the programme started before I joined, David. But I think we don't offer anything because we're a very small team ourselves. I'm not sure if NHS England do, Chantal. However, saying that, as a trust, we are looking into that as part of our Healthy Hospital offer, because I guess our core offer is we do the QUIT programme, and then we've got Chantal working on this programme, and then we do health inequalities training and MEC training, and that's what we do. But I, as a manager, I'm always looking at what can I do to influence the hospital around health inequalities. How can I help? And one of the meetings we've got with Good Food, I can never remember the name, Good Foundation, is looking at digital inclusion and how we can make sure our patients, when they need that support, to access services. So it's not something that we do at the minute, David, if I'm honest, but it is something I think as time progresses, we definitely need to do more of in hospital to support patients.
Yeah, that's fine. I say it's just for us to remind ourselves, isn't it? Because we
Yeah.
tying it into the IMD conversation, we know that those people might be less digitally enabled than others. And we have got a question in, and it's just about in the plan, sort of tracking the long-term metrics. So we know this is a program for 12 weeks, and do we kind of, is there a way we can sort of look and see that that's been a lifestyle change that people have maintained? Is that something that you've thought about?
Yeah, we'd love to track it. I don't know if Chantel wants to come in, but I know that the issue we have is because NHS England, I guess, are controlling a lot of this. So once we've done our bit, it's over to NHS England, and we're kind of at their mercy, really. So even just getting the information for the presentation, the IMD, we've had to ask them because they hold that centrally. So we don't track it at Rotherham Hospital. Chantel, anything to add from your perspective?
Yeah, I think the evaluation, the 150, was only because we wanted to feed back internally to our specialists as well. So once a referral goes from us, it goes directly. And I think, like you say, it'd be good if we could do some further evaluation work to see whether patients then continue the programme beyond the 12 weeks, because sometimes on the elective surgeries, especially hip and knee, they can be on for 9 to 12 months waiting list. So we're actually getting them at the point when they're coming into outpatients and suggesting the starter programme, which is 3 months in duration. But what we want to do then is for them to continue it over after that. Because I think, again, that's something that we need to start looking and scoping, but it's having the staff availability to do that. Yeah.
I guess if there is a lengthy wait, but you are seeing them at surgery, I guess there is a touch point, Chantel, that you might be able to record a BMI. So that might be something that might be worthwhile in the broader sort of healthy hospital type program. I've got another question that's come in as well. Are you able to describe the work you're doing with the tier 1 space, the prevention community? That might be a little bit out with your remit, but I guess it's the connections of, you did reference about, it's public health commission services, isn't it, tier 1 and 2?
Yeah, we do actually. I think we've trained just shy of 400 people at Rotherham Hospital on a 3-hour training program, which includes health inequality. So we cover health literacy, digital exclusion. We look at the protected characteristics and the inclusion groups. And then as part of the end of that, we do a MEC session. So making every contact count. And within that, we talk about smoking and we talk about weight management. And it's really for our frontline clinicians at that level 1 where you're seeing patients with these health issues to make sure that you're talking about prevention and it's not somebody else's issue, but actually us as clinicians need to address that as well. And we're so delighted, actually. I can't believe we've had, when I look at it, and I get colleagues from STH, Sheffield Teaching Hospital, say, how are you getting people to come to a 3.5-hour training session on MEC and health inequalities? But our colleagues are really interested and they give us really good feedback. And we also have an avatar. So actually before they leave the session, they can practice it. So they can actually practice what a MEC conversation looks like. And again, get really good feedback on that.
So I was at the clinical leaders meeting across both Barnsley and Rotherham Trust earlier this week, and making every contact count came up as a theme there. So one of the public health consultants, because it's not a new concept, and I think public health have been utilising that for a long time. So I think it's less known in the NHS forums, and certainly, as a doctor, there's kind of, I don't remember it being in my training. So I think trying to raise awareness of that is that actually there are points of time where we touch people's lives that we can have a real impact on them. There's a second part of the question. I think this was predominantly adult patients, wasn't it? But it sort of talks about families and children and young people. So it's just a bit of a prompt. Is that something that you considered a sort of an all age approach?
Sorry, Naz, I'll pick that one up if you like. So the criteria for NHS England was from 18 and above. So the actual pilot that we started, they gave us the categories already. So we didn't have much scope. I know there's been some recent articles about younger children that are school age with larger BMIs. And Naz, you've done some previous work in Sheffield with younger adults, haven't you? But yeah, we just stuck to the actual pilot scope at that point.
Yeah. I thought that's what you'd say, and suppose this is a kind of a small piece of work, a part of a bigger program. So appreciate that. So I think that's all the questions we've had. Well, before I wrap up the the session, I'd like to say thank you to Naz and Chantil today. I'll say I was really interested in what you've had to say, and we'll ensure that this is uploaded onto the South Yorkshire Innovation Hub website. I wish you well with all the good work you're doing, and I certainly will be looking out for any evaluation and outcomes, and I hope I meet you again soon. So I'll close the session. Thank you for your time, and hope everyone has a good day. Bye-bye.
Thank you.